Let's continue. This one is called PEN, Palisaded encapsulated neuroma, aka solitary circumscribed neuroma. So in low power, we can see one circumscribed, well demarcated nodule in the dermis. And when we have a little bit high power, we almost can see kind of some palisading nucleus mimicking the verrucane body of schwannoma. And then when we have higher power, we can see clearly this one cell differentiation spindle cell in the middle. But this lesion is kind of small. So you may also want to ask how to differentiate this PEN with true schwannoma. First, I want to tell you schwannoma is really rare in this superficial dermis. Usually schwannoma is going down deep into the dermis, even go into the subcutaneous. And then another feature is that we do not see Anthony A hypercellular and Anthony B hypocellular area in this PEN. And then another thing is that schwannoma you usually can see hyalinized wall vessel, and then this PEN you won't see this feature. So combine all of this, we can still make a clear diagnosis of palisaded encapsulated neuroma. And then when you do the staining, all of these are one cell differentiation spindle cell, so S100 and SOX10 should be positive. When you do EMA clouding to highlight the perineural component, usually just in the periphery. And then we're talking about another entity. This one is neurofibroma. So this entity is kind of different from the PEN and the schwannoma. Even from the low power, we can see this kind of a exophytic growth nodule in the dermis. And we can see kind of pale stroma. And when we zoom in, we can see clearly spindle cell tumor. But this spindle cell do not forming any structure. You can see they just like a swimming dolphin, spurs haphazard distributed in the stroma. They do not have a really well demarcated area to tell you where is the normal dermis, where is the neurofibroma area. So kind of intermingle together. So when you see this spindle cell, especially in low power, you do not see any fascicular growth, any storiform growth, any verrucane body. All of the feature like this, you need to think about whether it is a neurofibroma. So when you zoom in, you can see different kind of spindle cell. They look different. And then you can also see these guys. This is mast cell, because for this pale looking stroma, neurofibroma, usually we have this kind of myxoid material. Anytime when you see myxoid mucin area, you will see mast cell. So what are the components of the neurofibroma? Usually all of these spindle cells, there are three components. One is one cell. Around 50% of this spindle cell is one cell. So when you do S100 staining in neurofibroma, around 50% of the cell will be staining positive for S100. But there are another component in the neurofibroma other than one cell, that is perineural cell or perineural-like cell. that is positive for EMA, just like what we do the staining with the PEN in the periphery. And then another component is fibroblasts. So you can also use CD34 to highlight these fibroblasts. So if you really want to do the staining to prove you are right, you need to do S100, that is patchy, CD34 patchy. EMA also stains some of the spindle cell component of neurofibroma. This one a little bit different, still diagnosed as neurofibroma, but we can see this really distinct nodule forming this worm-like nodule in the dermis. Let's focus on the regular neurofibroma area to recap all the features. So we do not see any growth pattern we can recognize, like storiform, fascicular growth, herringbone, of course not. We just see this haphazard growth of this spindle cell. When we zoom in, we can see this spindle cell, they do not form any structure, because we know there are 3 populations in the neurofibroma. So no doubt to diagnose neurofibroma. How about this area? Kind of well demarcated, but they still identical, looks like neurofibroma. So when we see this structure, we are highly suspicious for so-called plexiform neurofibroma. But plexiform neurofibroma is not a microscopic diagnosis, because when you diagnose a patient as plexiform neurofibroma, that means you clearly tell the clinician that this patient had NF1 neurofibromatosis syndrome. So when you try to make this diagnosis, just in 2 situations. One is that clinician already write down in the history that this patient had neurofibromatosis syndrome, and then you see this plexiform worm-like structure inside a neurofibroma, you can diagnose plexiform neurofibroma. Another situation is that when in the gross examination, they already tell you they find this plexiform structure inside this tumor. That is another possibility you can make the diagnosis of plexiform neurofibroma, because when you make this diagnosis, you already tell this patient is neurofibromatosis. So you need to bear in mind. Another entity, we are talking about neuro differentiation thing in this chapter, but low power, you may think, why do you show me kind of like well differentiated, infiltrated, invasive squamous cell carcinoma? Because this is how this lesion exactly trick you when you go into this pig 4. In the first piece, really highly suspicious for well differentiated squamous cell carcinoma. We can see really high acanthosis. We also can see this nodule that's like infiltrated into the dermis. However, in another sample, you can see something is different from the usual squamous cell carcinoma. The dermis kind of difference. We can see this sheet solid growth of some of different population compared to the normal dermis. When we zoom in, we can see this cell had really granular cytoplasm. This is another neural differentiation cells called the granular cell. Do not confuse with the granulosa cell in the GYN in the sex stroma chapter. These are the different. This one is granular cell. And then we can see this eosinophilic inclusion. The buzzword is postular ovoid body of myelin. So when you see this population really syncytial growth, that means you could not find where one cell starts and one cell in their cytoplasm just merge together syncytial growth with this granular cytoplasm, really homogeneous growth in the dermis, and then you can explain this is PEH, pseudo epitheliomatous hyperplasia. This is not squamous cell carcinoma. This is a reactive pattern to the granulosa cell tumor. But you can imagine if you just have this shape, you will be really easy to diagnose this is squamous cell carcinoma, well differentiated. So always pay attention, even you have a limited sample. When you see something not like normal dermis, you need to figure out whether this is granular cell tumor. You can usually the granular cell tumor is positive for S100 and SOX10. However, in the gingival type, you may find both of these markers are negative, and also in the congenital type or non-neurodifferentiated granular cell tumor, you may find S100 and SOX10 negative. But the H&E feature will still give you the diagnosis of granular cell tumor. And then you can imagine if granular cell tumor happen in the tongue, and then you diagnose well differentiated squamous cell carcinoma, the patient will get a really big surgery, and then it's really dangerous to call well differentiated squamous cell carcinoma in the tongue area. So make sure you pay attention to the dermis. This is another one, granular cell tumor. See, you can see this really reactive pattern of the squamous epithelial called a pseudoepitheliomatous hyperplasia. Always pay attention to the dermis. Yeah, you can find this syncytial growth cell with granular cytoplasm with this eosinophilic inclusion, postular ovoid body of myelin, and then you can diagnose granular cell tumor. This one is a really rare diagnosis, but I also want you to pay attention. This is the growth picture, usually growth in the head and neck area with this nodule. And then the distinct microscopic feature is like this spindle cell kind of grow to form this nodule separated by these fibrous septae. And then the cellularity in this nodule is really high. And this cell kind of look like epithelioid, somewhat like spindle cell looking, kind of mimic maybe kind of melanocytic cell differentiation for this one. But when you do S100 and any other melanocytic marker like S100, SOX10, HMB45, MARCH1, all of these markers are negative, and not any specific marker useful to diagnose this tumor. We call this cellular neurothekeoma. So need to bear in mind if you would like to diagnose some melanoma in the dermis without any epidermis involved, and then you find all the melanocytic markers are negative, you need to back up. Could it be cellular neurothekeoma? Sometimes you may also see mitosis, really atypical cell in this diagnosis. But even that's still a benign lesion. What you need to do is just make sure you take the whole things out. This is another one. Low power really highly suspicious like dermal plaques melanoma, but usually they do not have any connection to the epidermis. And then high power, this spindle epithelial cell forming this nest separated by this hyaline stroma that is the characteristic feature. Of course, don't forget to order your melanocytic marker to prove this is not melanoma. You can see this nodule. If you go to high power, you can find mitosis. Some cell is really big, some cell really small, looks really atypical, really scary looking. But focused on low power, kind of reassurance, the cell separated by this fibrotic stroma. This one called atypical cellular neurothekeoma. Because this next is not as tight as the previous classic one, but they still forming this vaguely next separated by this stroma. You may also, this one is highly mimic like desmoplastic beast nevus, or maybe even desmoplastic melanoma, especially you can find this lymphocyte around. And then some cells look interstitial growth, and then you can see this tumor is really kind of infiltrated growth. But if you bear in mind it could be neurothekeoma, you can still kind of hallucination with a next separated by this hyaline stroma, and then you flow your melanocytic marker there, and then you find all of them are negative, and then you should be suspicious. Could it be just a typical cellular neurothekeoma? So this one is really good for you. Bear in mind what is this entity look like. So whenever when you see the derm case, do not go to really high power because it will make it scary. Really important, make sure we do not have melanoma in situ in the epidermis area. Then this is another variant. With low power, we still have really classic picture of nodule only in the dermis, no involved in the epidermis. Then we have this stroma, fibrous stroma separates this nodule. But another weird thing is that when you see the stroma kind of bluish, this is the myxoid stroma. So this is another variant of cellular neurothekeoma called the myxoid cellular neurothekeoma. So still the same thing. The weird thing just they have this bluish mucin and myxoid stroma. But the overall architecture are identical to the cellular